Okay, so hi everyone. So my name is Dr. Blessing Ofunsi. I've currently just started training in psychiatry as a CT1 with LSCFT Trust. Next slide, please. So since the doctor previously has talked about, different routes towards NHS as a medical student, medical graduate, I will only be focusing on F2 Standalone, and just talking about my experience in the whole process. So next slide, please. So a bit about me. Like I mentioned, my name is Blessing. I'm 26. I grew up in UK, did my A-levels in UK, but unfortunately I didn't get the predicted grades. So I had the option of either going through biomed and then postgraduate, or going, studying abroad. And I went through of studying abroad. Initially, I went to go to Bulgaria, but for some reason, I was redirected to Cyprus. So yeah, I studied in the University of Nicosia, Cyprus, and this was in 2015. It was a 6-year program. Fortunately for me, I had the opportunity of doing my last 2 years in Barnsley Hospital, which is in UK. So I spent 4 years in Cyprus, came down to Barnsley, my 5th and my 6th year. 6th year was seen as kind of like an internship year. And my course was fully taught in English, so there was no issue whatsoever. Graduated in 2021, and I did the F2 Standalone, finished in August 2022, and locumed for a year. Best decision of my life, loved it. And just because I was getting slightly a bit addicted to locuming, and I just had to enter training. If not, I would have just locumed literally all my life. So yeah, I applied for training last year and started August. Next slide, please. Okay, so F2 Standalone. So what is it? So normal UK graduate, or UK medical student, will go to uni for about 5 years, and then they graduate with provisional license. And because they graduate with provisional license, they have to do like this foundation training program, which is two years, F1 and then F2. So the F2 Standalone is where you join at the F2 stage. So it's a 12 months training program that is in the 2nd year of the UK Foundation program. Why should you consider it? So because a UK graduates with provisional GMC, they can't apply for the F2 Standalone, and because they're also in a training program and at F1 stage, they can't apply for the F2 Standalone. So it is predominantly like 90% an opportunity for us international medical students, for us to enter the system, NHS system, through the foundation, through a training program route. How do you apply? So application happens once a year, usually at the end of the year or at the start of the year, and through the REO National Online Application System. What are the requirements? Well, you need a degree recognized by GMC. So I would suggest, go on the GMC website. There's a link that has basically all the acceptable degrees by the GMC. You need to have a full GMC registration, or expected to hold. So when I applied, I was hoping to get the full GMC after graduation, and I didn't get my full GMC until like 2 days before I started. So a full GMC registration is required, and it's a must. And because if you were in a 6-year medical school, you graduate with a full GMC because your last year is seen as an internship year. You must not be working already in a UK foundation training, or hold an FPCC, which is what you get at the end of your F2 training. So it's kind of like similar to CREST. You've gained the competency and you're ready for training. So again, this is why the UK graduates can't apply for F2 standalone. And one of the process in F2 was in the declarations, you have to declare that you're not already in a UK foundation training, you're not in F1 training, and you've not, finished training and got in the FPCC. You need appropriate rights to work in the UK, and also you need to demonstrate good skills in listening, reading, writing, and speaking English. This is usually evidenced either by the IELTS and or 3 months, employment history in the NHS, and accepted evidence of English language proficiency. Next slide, please. Okay, so I'm going to talk about the application process through my experience. Hopefully that kind of helps. So in Jan, I created an Oriel account. I submitted on the 14th of Jan 2021. Next slide, please. So what was included in my application? So the first one, personal information, which in every application, so I have to name, my date of birth, my religion, my gender, my work, my rights to work, equal diversity. Then I had to talk about employment history. So I was fortunate enough to work as in healthcare. So I talked about that. I also talked about what I did in my final year that was seen as an internship year, doing discharge letters, go attending ward rounds, so just stuff like that. Agreements, again, agreeing that I am, not a UK found already in a training program. Then I had to list down 3 references. So these are people that I have worked with. And it's quite, if you are going down this route, I would suggest you pick your references date, you pick them wisely. The reason for this is because they need to fill out the form 2 weeks after the email has been sent to them. So I had to write a name. I had to write what their role is, what my role with them is, how long I've been working with them for, and I had to provide an email address. So you need the right email address, because if you don't get that, you're not able to continue. Fitness to practice, then declaration, and then supporting evidence. This is where I posted anything and everything. I created my CV, wrote everything down in my CV where I could sell myself. I think I even posted my passport, my Dean's Award, my ILS certificates, any certificate I got, any training I did, ultrasound training I did. I got involved in teaching, so teaching medical students. I used my church as an opportunity as well to teach those that aspire to be medical students as well. So I did some teaching sessions with them and got a letter from the church. So I did kind of that, audits and research. They love it. They love it here in the NHS. So I got myself involved in audit and got evidence for that. Not so research, unfortunately, but audit. And there's always an audit going on, especially in the NHS. If you are, working in the NHS, if you're walking abroad, you can talk to a consultant and you can pretty much make they're quite quick. So some of them can be just quite quick to do. So there's that. I'm just trying to figure out what else did I do. Leadership role. So I had to mention ways, I've managed evidence of that, and having evidence for anything that you do is quite critical. So at this point, I've supporting evidence is just selling yourself. Why should they pick you like any other interview? Next slide, please. Okay, so 21st of Jan, I got an email. Yes, I was deemed longly successful. I think anyone who was eligible all got this email. And then the next step for that was that I had to book the SJT, which I booked for the 11th of March. Next slide, please. So I think again the doctor just before me has spoken about the SJT. So I'm just going to run it run through it quickly. I've written here, it's not a test of your knowledge or skill, but rather to determine whether you have the attributes that are needed as foundation doctor. So it tests how professional you are, how ethical you are, and it's multiple choice or rank based kind of questions. So a common one that I can think of is you've noticed that your colleague is not, not their usual self. They're struggling with the workload. They're more quiet and they make more mistakes. Which of these out of the options would be the most appropriate? And then you have to rank them. Obviously, there's always a very silly one like report them to GMC. Yeah, but no. But there'll be stuff like, advise them to talk to the supervisor, advise them to talk to their GP, offers to speak to them. Is there anything going on? So these are the kind of options you would get, and you have to rank them in the most appropriate. Like the doctor before me said, there's not really the best way to prepare for it, but what I did was I went over Past Medicine. So Past Medicine is a great website. A lot of people use it. They use it for the GP exam, use it for the medical students, use it for the end of year exam. I'm going to use it for my my psych exam as well. So it's a very good website. And also getting yourself familiar with the good medical practice, guidelines, because all the answers from the past medical will reference what the guidelines what they say. So getting yourself familiar with what the guidelines and reading that will help you answer these questions. Next slide, please. Okay, so I sat the exam quite long. At some point, I had a headache, so I was just like, okay, yes, we move. And a few days before the results came out, they last minute changed things where they did this bypass. So if you scored really, really high on the SJT, you could bypass the interview and you get straight off, you go straight into the offers, which is a good thing, I guess, but I'm happy that I didn't score that high, just because I was a bit on the fence with this F2 standard, because a lot is required as an F2. You're expected to lead board rounds, you're expected to work more independently, you're working, you've got F1s working for you, F1s will escalate to you. So there's a lot of responsibility and knowledge that is expected. And at that point, I knew I was ready for F1, but I was not sure if I was ready for F2. And anytime I speak to a doctor at work, they're like, oh, no, just go through, just do a trustway job, which is very common. So I was very on the fence and worried about it. And I saw an interview as a way of, okay, if I pass this interview, that means they think I'm okay enough for the job, which was the kind of confidence I needed. So my results came out. I didn't get high enough to bypass, but I got high enough to go through the interview. So I had my interview booked for the 20th of April at 10 a.m. And next slide, please. And so the interview process experience, quite scary. It was a 20 minutes interview. I had two clinicians and I also had like an administrator who was just overseeing everything. I had to provide like an ID at the start to say I am who I am. Had to have my video turned on also, which was not really an issue. It was expected. I think I had to scan the room as well. I can't remember. But it was done online. It was done via Teams, and it was split into 4 sessions. So the first one was talking about my CV and employment history. And then I had 3 clinical scenarios. So 2 clinical and then 1 ethical. But ideally, on average, how an interview works is you get this CV and employment, and then you get a session talking about the system. So how much you know the NHS, how much do you actually know about the role that you're doing, and how it works. So there's that, and there's 1 clinical and there's 1 ethical. So that's how it usually works, but I have 3 clinical and I'm not complaining, because it worked out for me. Next slide, please. I hope you can see this, or you can zoom in and see this. So this is what they sent to me in terms of my the report and how I did, which was it helps me remember, because I genuinely forgot about how the interview, the questions were. So I remembered that. So after I showed my ID and my passport. So bear in mind that I've already sent my CV, and my first line, the first statement on my CV was that I'm a final year medical student who is this, blah, blah. So I already sent this. So the interviewer, the first question he goes and he asks is, talk to me about your experience after graduation. And in my head, I'm like, wait, I already told you I'm a final year medical student. I've not graduated. But, I kept my calm. And then I was like, firstly, I just want to clarify that I have not graduated yet. I'm still in my final year. And he was like, what? No, how is that possible? So I was really shocked, because he should know that what the role is, and what my portfolio and my CV was. And then he was very, very intimidating, which made it more nerve-wracking. But I still kept my calm and I still kept my cool. And so I talked to him about, what I've done in my internship here, the audits that I've done, the teachings that I've done, what I've done, like, helped out with discharges, attended board rounds on calls that I've assisted with, really trying to sell myself like, okay, yes, I am capable. And then we moved on to the first clinical scenario, which was about a heart attack. So it asked me the questions, and I answered how I would assess it and what I would do, which went all right, because I did prepare for the interview, and I'll talk about how to prepare, and what you should, how, and tips. So I did prepare, and because I had my A&E placement, I attended A&E there, I was helping out, and I was very proactive. So I pretty much was quite confident. So, and I'd done my ILS as well, and I think helped to assist ALS trainings. So I knew how ALS was. I think I assisted about 3. So to an extent, I already knew the AT and exactly how to do it. So it really helped me. So I didn't have any, like, I didn't say I didn't have any problems, but I was confident enough in the clinical. And then I had a second one about anaphylaxis as well. Again, went through my AT, what exactly I would do. And then my clinical scenario, they asked me about, it was an ethical question, which there was no way I could prepare for this ethical. I just went by what I'd done already for the SJT, and I think it was about a safeguarding, and I think they prompted me, the second lady, who was way nicer than the first one, she prompted me in who would I escalate to, or I'll discuss with safeguarding, which I didn't really get, but she was very quite helpful. So that was about it. So each section, for my employment and the 3 clinical, is 20%. You get scored on that, and then you get a score 10% on your communication, and you get a score on your knowledge of English as well, 10, and overall you get like an overall percentage. And yay, I passed. I don't know how, because I was adamant that man was going to fail me, but luckily he didn't. Next slide, please. So interview tips. So CV and employment section, talk about if you've not graduated, talk about what you've done, what you're doing in your internship year. And it would be nice if you know what an F1 does, and make sure if you can work towards you doing exactly the same thing, and then talk about what I've done this, I've done that, which is exactly what an F1 would do. I made sure I got some F1 competency form during my internship year, and I got that signed off as well. So I've got the F1 competency skills, which you can always find online. And your current job, of what you're doing as your current year. Teaching experience is very key. They love teaching here in NHS. Teaching is very key. Audits are very key. Leaderships are very key. So the moment I knew this, I just looked for any opportunity, and if I couldn't, I just created an opportunity. So yeah, that's that. Next, please. Sorry if I'm talking a bit fast. I'm just trying to make sure I don't exceed the 20 minutes. So this is the second section, which ideally I was meant to be asked on, but I wasn't. They gave me another clinical, not complaining. So it's knowledge of the foundation program, knowledge of GMC, good medical practice, knowledge of what is expected as an F2 compared to an F1, what's the difference, management as an F2 training, what is an expectation. So knowing exactly what the role is you're applying for, like any other interview. So that's going through the job requirements, what is expected will help prepare for that. Next, please. Okay, so in a clinical, sorry, that's it. So in a clinical scenario, master UAT assessments. The Oxford Handbook has a section at the end where emergency section have like a flow chart. I just literally just mastered that. So once they gave me the questions, I just started from A to E. So number one, I would do my AT assessment. I would check, is the airway patent? If not, I would escalate to anesthetics and secure the airway. B, I would, get a set of obs. What's the respiratory rate? What's the oxygen sats? If the oxygen sats are low, I'll give them 15 liters high flow. I would listen to the chest. If there's at some point they will tell you, okay, this is what is wrong, and this is what I have to fix. At some point, then oh, okay. So I think when I got to my C, I did an ECG. ECG showed ST elevation. Okay, I knew this was a heart attack. I start my mono treatment. Then I know I need to escalate to find the nearest center. So as long as you go through your AT assessment, which is what is expected of you as an F2, when they call you to go and see an ill patient or managing an ill patient, you have to go through your AT assessment. Is what they teach you in your induction as well. Even in ALS is all about A2E assessment. So it's pretty much, can you deal with managing an ill patient? And can you know, they also want to know, do you know your competency? Do you know what you're competent in, what you're able to do? Do you know when to escalate? I remember when I was in my F2 standalone, in one of my trainings, we had a session, stimulation on managing ill patients. And then I had a lady who was having an asthma attack. And one of the criticism I got was that I didn't escalate early enough, which was a bit weird because I was like, don't you want me to, see what it is I can do? And we're like, no, you had to escalate. If you know that this lady, she had a background of she's previous admission in ICU, so you already know this lady's high risk. At this point, you should have escalated to your senior. And so knowing when to escalate, they'd like to know that. So yeah, master your AT assessment. Once you've mastered that, trust me, you will feel absolutely comfortable. Next slide, please. So the ethical scenarios, so dealing with complaints, junk, these are kind of topics you would get. I'm not really going to go into that because I think the gentleman that did the interview tips talked about the SPICE technique. So I'm not going to just repeat what he said. Next slide, please. And yeah, so that's the SPICE. So I'm not going to talk about that. Okay, so results came out from the interview, and they came out on the 26th. Yes, I passed. I was really grateful. And then from the 27th, we got an email where that prefacing was open. And so what that is all the available jobs, F2 jobs. I had to rank which one I would most likely accept and which one I wouldn't. So in 2021, there was quite a lot for us. But I noticed in 2022, my colleagues who applied, there wasn't quite a lot. It became more competitive. So again, I think I was really lucky. So I ranked based on, I wanted 3 jobs just because, again, I wasn't so confident. So I wanted jobs where the support was quite high. So I wanted psych because in psych, you don't really make a lot of decisions in terms of management and treatment plans. The consultant usually does, but in terms of physical health, we are pretty much involved. So I wanted psych, I wanted A&E, which I thought would boost my clinical competency, and I wanted a GP role as well. So that was what I wasn't bothered where I would be in. I just wanted those 3 jobs. So preferencing closed on the 4th of May. I got an offer on the 5th of May, which is my second option, Grimsby. I didn't even know where it was. I was just looking at the jobs. And then those that I I kept down for references, had 2 weeks to complete it. If not, they had to cancel my application. So luckily, I was chasing them, sending them an email. Don't forget. And that was all done. And so I graduated in June, and immediately after graduation, then I started working on my GMC application and getting my GMC license, which took quite a while because I had to go through, I can't remember who I had to go through. I had to go through one US agency or something. So it was quite long. I don't know what the process is like right now, but like I mentioned, I got my full license like 2 days before I was to start. So yeah, my training post started in August. Next slide, please. So like I said, I had 3 jobs, so psych, A&E, GP. They lasted for 4 months each. So it was rotational. I was still, as an F2, I was still under clinical supervision. I would meet my supervisor to go through my portfolio. So I had a portfolio, and I had some competencies I had to do, some DOPS, so some clinical skills, like in terms of like cannulas, bloods, catheters, nerve blocks. So I had to get those done. History taking, case-based discussion, reflections, attending teachings. So I had all of this that I had to do, and I had a supervisor that was, helping me. So I had a clinical supervisor in each of this clinical jobs. So psych, I had one, A&E, I had one, GP, I had one, and then I had an overall educational supervisor. As an F2, I had to make management decisions, especially in GP. GP, I had my own sessions that I was running. I had my own, patients that was coming, so I had to document, I had to manage. Obviously, I still had a supervisor that I could talk to, but they also had their own sessions they were running. So imagine me as an F2 always going, okay, can I discuss this? No, they expect you to work independently, and then at the end, talk about what exactly it is you're doing. I was involved in more teachings. I had to do more teaching sessions with F1s, with medical students. You're expected to lead ward rounds. So for psych, I was expected to lead MDT reviews. I was expected to do section 5.2 assessments, capacity assessments, which F1s could not do. Again, more is expected. And with psych, a lot of this, you have to have a rationale, because if anything happens, you're the one that's going to stand in court because you filled that document, that legal document. So there was a lot of responsibility as an F2. My experience in my jobs, absolutely love psych, because I was very interested in psych. My supervisor was very supportive, gave me quite a lot of opportunity, helping hand in hand. Physical health, there was not a lot of support, so the psych consultants don't really know much about physical health. So a lot of time would have to escalate to medical reg, and imagine we can't do bloods there and get the bloods immediately like he'll do. We don't have access to cannulas. We just had bloods, oxygen, just the management. So a lot of time it was speaking to med reg, speaking to surgical reg. A&E, again, absolutely loved it. The support was amazing. I had amazing registrars. I had amazing consultants. It was not as intense I would think it is. You think A&E is quite intense, but it actually wasn't that intense. You go at your own pace, you go and see a patient, you document. A lot of learning that was going on. It was my second choice, really. It's just the working hours is just crazy. That's why I didn't pick it. But I locumed in A&E for a year. Again, absolutely loved it. GP, I struggled with GP just because I was more on my own. And the workload was piling. It was quite a lot. 20 minutes to see, examine, document, treat. It was quite huge for me, and they kept on piling on top of my list, and I was struggling, and then I kind of made some mistakes, and then the supervisor weren't really so helpful. So that was probably the worst job for me, but again, each to their own. Next slide, please. I'm almost done, guys, don't worry. So lesson I learned, you learn on the job. There was a lot of things I picked up on the job, just talking to colleagues, watching other colleagues do. So you learn on the job and eventually you will get there. Escalate whenever you feel, even if you think this is very silly, this is very stupid, the worst they're going to do is they're going to shout at you. The worst they're going to do is they're going to make you feel bad about yourself. Brush it aside. Your main priority is the patient's priority. I want to make sure my patient is safe, because if my patient's not safe, then it's going to come back on me. Why didn't you escalate? So escalate whenever you feel not comfortable. And everyone is also learning. So I, at the start, was like, oh my God, I don't know what it is I'm doing. I don't know what it is I'm doing. But everyone around me felt the same way when we actually talk about it. So there's an imposter syndrome, which I've heard of, but I didn't believe it, but it actually is real. So you're just as good as any of the doctors, and just know that. Remember, it is a training post. So lesson I learned is a training post. It was an opportunity for me to be more proactive, get involved in teaching, and which is the downside in locum. As a locum, you're not allowed to attend teaching sessions because you're paid just to work. So I didn't benefit from that. No one needed to sign me off or anything. So you technically are, it's an opportunity for you to grow. So being more proactive, that's what I wish I did more in F2, but hey, it is what it is. Pick Western Island. I was picking my jobs wisely. I had colleagues who picked medical jobs and had to drop out because it was quite a lot for them. And know what you can cope and what you can't cope with, and I knew what I could handle. So I picked my job wisely, which was a good lesson that I learned. Don't leave your portfolio to last minute. Portfolio is quite heavy, no matter what. If you're foundation training, a GP training, site training, any training, just work on your portfolio as you go along. Oxford Handbook, really good, really good. It was my go-to. I think I was one of them that would run through the toilets to check something, but after a while you just get used to it and you just pick it up. Being friends with nurses are so great. They can either make or break you. They know a lot and can help quite a lot. So being friends with nurses was one of the best things I did for myself, and just enjoy it. Enjoy the process. And yeah, that was the lessons I learned. That was my experience, and I think that is it. The next slide, please. So yeah, this PowerPoint is available. This is a useful website that tells you about the foundation program, what it's like, the GMC, and finding out if your degree is acceptable. So these are useful websites that you can look